not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the Livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 10 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM Livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the Livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 5 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM Livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the Livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval.
Good morning, everyone. I am Dr. Ria Salonga Kimpo, Mu Sigma Phi Sorority Batch 2004, speaking in behalf of the Aging and Longevity Webinars team of the Mu Sigma Phi Sorority. We are streaming live from the video conference room of the UP Manila Information Management Service. Our time in Manila is now exactly 12 noon. For today's webinar, we are privileged to have distinguished alumna of the UP College of Medicine Class 1990. She took her residency in neurology in the University of Connecticut Hartford Hospital program from 1996 to 1999, where she also served as a chief resident from 1997 to 1999. She then took her 2 fellowship programs in experimental therapeutics and movement disorder and experimental therapeutics and neuroaids in the Instructor University of Rochester Strong Memorial Hospital. Currently, she is the medical director of the Movement Disorder Center, Hartford Healthcare Neuroscience Institute in Vernon, Connecticut. She is also an associate professor in the University of New England School of Osteopathic Medicine in Maine. Ladies and gentlemen, we are honored to welcome Dr. Joy Antonell de Marcaida, Mu Sigma Phi Sorority Batch 1990, who will be speaking from Hartford, Connecticut, USA.
Good evening, Dr. Kimpo.
Good evening. Good evening.
I'm really happy to be joining you, and I'm happy to have the opportunity to address our colleagues in Manila and in the Philippines. Today, I was going to speak about the management of motor fluctuations in Parkinson's disease. I thought that it was important to focus on specifically the management of motor fluctuations because Parkinson's disease is quite a complex and diverse condition that can be accompanied by so many other signs and symptoms. My disclosures are as follow, and the objectives of tonight's this This afternoon's talk is to recognize the phenomenology of motor fluctuations in Parkinson's disease, as well as to recognize the spectrum of adjunctive pharmacotherapeutic options for management of motor fluctuations. We want to talk about the efficacy and tolerability of each of these drugs. So for Parkinson's disease, the current medical
Right.
management really focuses on dopamine
Excuse
replacement.
me, can we interrupt for a bit? Could you show your slides? Because we're not seeing it on the screen. Share, please share.
Can you see it now?
Yes. Uh, you could minimize the video
That's
connect
good.
window. Uh,
Okay. Are we
all
all
right.
set?
Yes, that's better. Thank you.
Okay. But
All
now
right.
I've lost control. Okay. I lost control of my slides.
All right.
So, as I was saying, the treatment of Parkinson's disease focuses on dopamine replacement, but the limitation that we have found with levodopa treatment for Parkinson's disease is that as the disease progresses, we are finding that the efficacy gets less and less um, prolonged in terms of how much you can achieve that therapeutic window that is desired. In this slide, you see that early on in Parkinson's disease, a medication that is taken at this point will last several hours. And you see that the sweet spot is between these two lines, similarly in this area. But as Parkinson's progresses, that sweet spot that lies in between gets smaller and smaller. And although you take the same amount of medication, you will find that it it takes a longer time before you can get into that peak effect of the medication. And then after a while, it doesn't take much for that peak effect to progress into a toxicity, which will manifest with a phenomenology called dyskinesias. And I'm sorry, Darwin, I am not able to control my slides at this point.
Ay, Doc, pakiclick lang po yung slide niya.
Yeah, so I'm clicking on my slide and it's not, there we go. Okay, all right. So furthermore, these motor fluctuations can manifest in many different ways. In this slide, we see the typical wearing off of the benefit of the medication. So at this point, the levodopa is taken. It might take a little while for that to kick in. You get into that optimal effect and then it wears off before you're ready to take your next medication. In this particular example, there's a dose failure. The person takes his levodopa here. It doesn't work at all until several hours later, and only at that point do you see the peak effect of the medication. There are people who have random on and off periods where they take the medication as scheduled, and you see the arrow points here, and yet the therapeutic effect can happen at any point, and they can wear off and be in an off state despite taking their medication on time. This graph on the right side is one person taking their medication as scheduled. And again, the arrow points are the points at which the person is taking their levodopa dose. Yet the person takes it at 7 o'clock, nothing at all happens for 3 hours, and they're off for this entire period of time. They take their second dose, and all of a sudden, there's a pharmacotherapeutic effect, and they get into that sweet spot in the middle where they are on. It doesn't take long, though. Within a couple of hours, that medication is again wearing off. They take their next dose and they're back on. And look at this one. At 5 p.m., he takes another dose and it overshoots that sweet spot, and they are in this toxic level of medication where they have dyskinesias. So that is the challenge of what happens after many years of Parkinson's disease, and that is what we refer to as motor fluctuations. So the on state that I had been alluding to earlier on is when a person with Parkinson's disease takes their medication and they feel like their Parkinson's is under control. So they feel as close as they used to feel before they had Parkinson's disease. Their medication is taking care of their symptoms. Optimally, this should last about 4 hours. The off state is when the medication seems to be not working anymore and they have a return of their Parkinsonian symptoms. They're slow, they're tremoring, they're having difficulty walking. Furthermore, there are people who manifest with non-physical signs of their off state, and that can be even more devastating. People will talk about getting into a panic attack, having abdominal pain, excessive sweating, irritability, they feel foggy headed, they get anxious and depressed. So the manifestation of off and the manifestation of Parkinson's is not only physical. We recognize now that these non-motor off states can be even more devastating to our patients with Parkinson's disease than the physical manifestations of their Parkinson's. So in this slide, you see that these motor fluctuations are occurring in almost the same number of people as those who have motor fluctuations. In the survey of about 50 people, all 50 people in that survey said that they had non-motor fluctuations in addition to their motor symptoms with their Parkinson's fluctuations. There is another phenomenology, though, that I also mentioned earlier, when there is an overshoot of the pharmacologic level of the levodopa, and people manifest with a toxic effect called dyskinesias. Dyskinesias are involuntary writhing movements called chorea or athetosis, which is actually a side effect of the medication. A lot of us are very grateful for the advocacy of Michael J. Fox in the world of Parkinson's disease, but people see him on television and they see him wriggling and writhing around, and they think that that's what Parkinson's disease is. Actually, that is a side effect of the levodopa called dyskinesias. Dyskinesias can be just as devastating to people with Parkinson's disease. So in the US, we have 26 medications for Parkinson's disease. And the intention of having all of these medications is to keep people in that on state. So we do whatever we need to do to keep them going, to keep him driving his jeepney or his UVS, because even if he's dyskinetic, he can still function. If he's not dyskinetic and his medication wears off, he actually cannot move. So the 26 medications are used in combination because each of them work on a different mechanism. All of them have the final goal of increasing dopamine, but they increase dopamine in different ways. They can stop the metabolism by inhibiting the enzyme COMT, which breaks down dopamine. They can enhance dopamine by blocking MAO, which is the other enzyme that metabolizes dopamine, or they can pretend that they're dopamine through a mechanism of agonism. So as dopamine agonists, they bind with the receptors and they continue to function as though the person is receiving dopamine. However, the medication that we were referring to from the get-go is levodopa, and levodopa is direct replacement of dopamine in the system. In the spectrum of the disease, we use all of these medications either early or late. As we get into more advanced stages of Parkinson's disease, then we're using multiple medications. In Parkinson's disease, polypharmacy is actually preferred over monotherapy because by adding other medications, we're able to keep him in that on state. So levodopa we talked about, it's a gold standard of therapy. It's still the best medication that we have for Parkinson's disease, but it has those limitations. Again, here in the US, we have many formulations, Cinemet, Cinemet CR. We have Stalevo, which is a combination of levodopa and entacapone. We have an orally disintegrating levodopa formulation. We have a new formulation, combination IR and CR. And we have an intestinal gel that is a continuous infusion of levodopa directly into the jejunum. One of the things that I'd like to share with you, with the audience, is that there is a misconception about levodopa CR, the regular Cinemat CR that is available readily. It is not any better than Cinemat IR. And you can see that the pharmacokinetics would be that the orange line is Cinemat IR, levodopa IR immediate release, and you see the peak of the level in the bloodstream and the wearing off after 4 hours. But look at Cinemat CR. It doesn't peak, so they don't have that same level of benefit after taking their medication, and it wears off after 4 hours as well. So there's no extended benefit by taking levodopa CR over taking IR. Furthermore, CR tends to be more unreliable. The new formulation that has...
Excuse me, Dr. De Marcaida, could you share
Yes.
your slides? We couldn't see the slides.
Why do we keep losing the slides?
Thank you.
Is that good again?
Yes, yes,
Okay.
that's good. Thank you.
Okay, so the other formulation, Rytary, which is available here in the US, showed that the combination pill had more improvement in on time of about 2 hours, 1.8 hours. And this is the intestinal gel that I was referring to. So it's continuous infusion of the levodopa directly into the jejunum through a pump. And again, I lost control of my slides. We are having a lot of technical difficulties tonight.
Happy Thanksgiving.
I guess so. The technology is on holiday too.
Yeah.
And truly, I can't advance my slide again.
Doc, please click the presentation po.
There we go.
Apo.
And you can see that the pharmacokinetics for the levodopa infusion is practically a straight line. So you don't have those fluctuations that we were seeing earlier with IR. Dopamine agonists, as I said earlier, pretend to be dopamine and bind with the receptors. It has longer half-life than levodopa and is usually used either as monotherapy when people are first diagnosed with Parkinson's disease or in addition to levodopa to make it last longer. The thing to remember about dopamine agonists is that the side effect profile is a little bit different than levodopa. There is an increased propensity to develop impulse control disorders. You can also get that with levodopa, but much more so with the dopamine agonist. What that means is that even people who never gambled before can develop pathologic gambling, pathologic shopping, pathologic sexual behaviors. So you have to make sure that you are advising your patients about impulse control disorders. It can also cause sleep attacks. What I'm showing right now is one of the dopamine agonist formulations, which is a patch. So rotigotine transdermal also has very nice pharmacokinetics, 24-hour duration of benefit, as opposed to some of the oral medications such as ropinirole, pramipexole, and previously bromocriptine. Bromocriptine is not used too much anymore at this point. MAO inhibitors, as I showed earlier, the inhibition of the enzyme that metabolizes dopamine will allow the medication to last longer in the system too. We have 3 MAO inhibitors there was an improvement in on time of about 1.9 hours versus placebo of 0.9 hours. What is interesting is that rasagiline, which is Azilect over here, was compared to entacapone in Europe, and they found that the duration of benefit or the improvement in on time with rasagiline, which is once a day, is equivalent to the improvement in on time of entacapone, which you have to take with every dose of levodopa. So this once a day, one pill once a day, seemed to be as efficacious as a medication that you had to take every single time that you took your levodopa. And had a much better side effect profile. Safinamide is a new MAO inhibitor that became available in the US probably in the last 2 or 3 years. What's interesting about safinamide is that it has a second mechanism of action besides being an MAO inhibitor, which is believed to improve dyskinesias as well, those involuntary movements that I showed you earlier. So there's a possibility that safinamide can improve on time without worsening dyskinesias. And we see the benefit of safinamide over placebo as well. So legiline is really old. It's from the 1980s, and the side effect profile is a little bit more than the newer medications, so higher incidence of neuropsychiatric side effects, insomnia, and other things. COMT inhibitors are entacapone and tolcapone. Both of them, the main thing to watch out for side effects would be GI. People would develop nausea, diarrhea, and with tolcapone, there was a post-marketing experience of 3 cases of fatal hepatotoxicity, which caused it to have a black box warning and require liver function testing on a regular basis. But COMT inhibitors would also prolong on time, as shown in this graph, by about an hour as well. Tolcapone, which is the one that had those 3 cases of hepatotoxicity, is actually more potent than entacapone. Again, there was a head-to-head study, not in the US, but they showed that tolcapone actually had a greater improvement in the UPDRS rating score, which is the Parkinson's examination score, as compared to entacapone. However, the limitation is the hepatotoxicity that can occur with tolcapone. Istradafilin is a new medication. We're very excited about it here, and I don't know if it's available there, but this is the first non-dopamine-based medication for Parkinson's disease. The mechanism of action is that it's an A2A adenosine receptor antagonist, which also is indicated as an adjunctive to levodopa to prolong on time and decrease off time. In addition to all these, when people still develop these off periods, despite taking their medications, despite the polypharmacy, we are grateful to have on-demand therapies. We used to call them rescue drugs. The first rescue medication was apomorphine. It's a subcutaneous injection. It's actually a dopamine agonist. It is not morphine, which is something that patients worry about. The response to these injections are almost as robust as levodopa. So levodopa is the best medication we have. An apomorphine injection can achieve that much of an improvement in patient symptoms, and it acts within 7.5 to 10 minutes. It can last for about an hour or two, so it's just enough to get a person from wearing off period into the on state so that they can wait till their next dose is due in an hour or so. The new rescue medication or on-demand therapy that became available this year is the levodopa inhalation powder. So this is also levodopa, but instead of taking it orally, it can be inhaled, and therefore it bypasses the GI tract and all of the limitations of GI absorption and GI motility problems in Parkinson's disease. So similar to apomorphine, the onset of action is quicker, and it can get people into the on state very quickly until they're ready for their next dose. If, despite taking all of these medications and trying all the things that are available for Parkinson's disease at this time, people still do not do well, as Neil had demonstrated, unfortunately, we weren't able to see him in his off state. But if we have tried all of these different classes of drugs and people are still not able to function, still not able to do what they need to do, then there are still the surgical options for Parkinson's disease. Deep brain stimulation is very effective for decreasing dyskinesias and improving on time. In the US, we have 3 platforms for DBS at this point. We have the Medtronic Activa system, the Abbott Infinity system, and the Boston Scientific Versailles system. They have differences in their technology, which make one beneficial for certain things as opposed to the other, but all of them have significant efficacy for improving motor fluctuations in Parkinson's disease. Newer surgical procedures that are in the research phase are focused ultrasound, which is already FDA approved for essential tremors in the US, also approved for tremors in Parkinson's disease, but not yet approved for the bradykinetic rigid manifestation of PD, not at this point. And we talked about the duopa intrajejunal pump system, where there's infusion of levodopa into the jejunum, and soon to come as well, we hope, will be apomorphine continuous subcutaneous infusion. So these are now the surgical options or device-based options for treatment of motor fluctuations in advanced Parkinson's disease. So despite all our technical difficulties, we got to the end of the slide. Thank you very much for your attention and your interest. I hope that that was helpful.
Thank you, Dr. De Marcaida, for that comprehensive talk, and thank you for bearing with us with all the technical difficulties. So right now, we have 514 participants viewing via Facebook Live. We have 33 on the YouTube live stream and 32 via the UP Manila live stream. So
Welcome, everyone.
the floor is now open for questions from the audience. So you may type in your questions at the Q&A chat box in the lower right corner of the live stream window, or type in the comments in YouTube Live or FB at Aging Webinars for Facebook Live users. All right. So I think we have our first question. So first question, is there a way to prevent or delay the onset of Parkinson's disease even when you're genetically predisposed to it?
Yeah, so that is the holy grail of researchers in Parkinson's disease. We would love to find a cure. Disease-modifying therapies are not available at this time. What the focus has been is that although we have not found a medication that will slow down progression or prevent it, we are finding that a healthy lifestyle overall certainly has its benefits in terms of even for dementia, for Parkinson's disease. We are finding that exercise, healthy living, eating healthy can make a difference in preserving brain cells.
How soon is the surgical option offered for these patients with difficult to treat dyskinesias? Right now in the Philippines, we do have DBS, but I think largely the experience is on XDP. Because they have had research on XDP here. And I think only, of course, the cost is the other major limiting factor. But I guess for patients with PD who are relatively early on in their disease, and let's say for those who will be able to afford, when do we advise them that DBS may be the appropriate treatment?
So it used to be that surgical options were only offered when people were more advanced and not responding to medications as well, when they have motor fluctuations or dyskinesias. Now we're finding that as early as 4 years into the Parkinson's disease, so long as they are tremor predominant, which is a symptom that does not always respond to medication, they may be a reasonable surgical candidate. The decision of early DBS versus late DBS, however, is still something that is very much a matter of discussion between patient and doctor. So there is no hard and fast rule, and it's still a controversy in neurology and in movement disorders as to whether there is really a benefit to doing DBS early versus later on. But it can be effective even as early as 4 years.
All right, thank you. And it's really good to know that even as early as 4 years, you could already start planning, because here it's mostly majority is out of pocket. So our patients really need to prepare for a costly intervention like that. We have another question here. Are there any important comorbidities of Parkinson's disease that we should address?
Yes, yes. When I was talking about the non-motor symptoms, it's a whole topic altogether, but there are so many comorbidities, so many non-motor symptoms of Parkinson's disease that are just as debilitating as the motor symptoms. Depression, anxiety, dementia can all occur with Parkinson's disease and must be addressed and treated. Parkinson's disease psychosis is another condition that occurs with Parkinson's disease. There's autonomic dysfunction, so orthostatic hypotension, constipation, um, uh, cardiac arrhythmias. So all of these things can occur with Parkinson's disease as well. So yes, um, for a talk like this, we want to focus in on just very specific topics, but there is so much more to talk about with Parkinson's disease as we learn more and more about the condition.
Thank you for that. I think there is another question here. Is there any way to recognize very early signs and symptoms of Parkinson's disease? Because, as you know, a lot of times, especially in the Philippines, patients don't come to us until the symptoms are already severe or obvious. Are there any particular signs and symptoms that would be kind of good to recognize early on?
Yeah, so the cardinal symptoms of Parkinson's disease are bradykinesia, which is slowness of movement, plus one more of these three symptoms, a resting tremor, rigidity of the muscles, and postural instability. So those are the four cardinal symptoms of Parkinson's disease. To make a diagnosis of Parkinson's disease, you have to have bradykinesia plus one of those other symptoms. And then, of course, you want to rule out other secondary causes of these symptoms that can look like Parkinson's disease. When you talk about early symptoms, we're talking about premotor symptoms of Parkinson's disease, but I don't think that you should use that to make a diagnosis early on. To make the diagnosis, you have to have those physical symptoms already. In retrospect, however, what is interesting is that when you see that somebody has a resting tremor and you're not sure whether it's essential tremors or Parkinson's disease, you can ask about these premotor symptoms, loss of sense of smell, constipation, REM sleep behavior. And if you have particularly REM sleep behavior and loss of sense of smell, the likelihood is higher that that person actually has Parkinson's disease. So when you have constipation, loss of sense of smell, REM sleep behavior, um, these are symptoms that can occur decades before the onset of the first motor symptom. So in retrospect, it's interesting to ask patients about this, but I would not use those as the basis for making the diagnosis when they do not have the cardinal features.
Thank you very much. We have a question here from Dr. Wilkos Parcon. His question is there a pharmacogenomic treatment modality for PD?
So that is something that is of greater interest now. Not yet, but personalized medicine is pretty much the breakthrough in all of the fields of medicine. But at this point, no, we do not have that.
All right. I think that's our last question for. Oh, there we have one more question. Sorry. Someone just punched in a question. How would you advise family members who are taking care of a Parkinson's disease patient in terms of trying to take care of this patient at home?
Yes, so I think that early on, it is not as much of a challenge to keep your loved one well. As I was showing in the slides before they conked out on me, the early Parkinson's disease patients are very responsive to medication. So they do well on the levodopa. We have a honeymoon period when they feel that they do not have Parkinson's disease at all because they're taking their levodopa. As the disease progresses, however, it becomes more important that the family members encourage and help their loved one take their medication exactly on time. So that becomes crucial because when they wear off, it becomes more difficult for them to kick back on. So taking the medication exactly as scheduled helps them stay in the on state much more frequently and on a more stable manner throughout the day. In addition to that, being aware of all of the non-motor symptoms, as we discussed earlier, is important because you want to address depression, you want to address anxiety, you want to know if your loved one is having hallucinations or paranoid delusions, and if you find that they are having these other symptoms, then to address it with their physician. One other thing that becomes challenging for family members is when their loved one with Parkinson's disease starts falling. So that's another major challenge in Parkinson's disease. And there are so many reasons for falls. So trying to figure out what you can do to prevent the falls is going to be important as well.
All right, thank you. There is another question here. What would be the best, or is there an optimal drug to take or give in combination with your levodopa to prevent the dyskinesias?
Yes, so all of the medications that I discussed in the presentation are effective for adjunctive treatment with levodopa, meaning that they do improve on time, increase on time, decrease off time. But you're right, many of these medications will then potentially induce or worsen dyskinesias because they're trying to increase dopamine and therefore overshooting and getting to that point when people will have the dyskinesias is potentially going to occur. There are medications that are specifically used for dyskinesias to counteract this effect, and that is amantadine. I didn't include it in my presentation because I was primarily talking about treatment of motor fluctuations or off states. But amantadine can be used to decrease dyskinesias. Um, there is a formulation of amantadine here in the US called Glucovri. It's um, it's a novel amantadine formulation that was shown in clinical trials to improve on time and as well as treating dyskinesias. There is also the possibility that the new medication that I mentioned, safinamide, with glutamatergic properties, can also improve on time without worsening dyskinesias.
Um, Another question we just got: how do we manage the coexistence of depression and Parkinson's disease? And how prevalent is depression in patients with PD?
Yes. So the management of depression in Parkinson's disease is no different from the management of depression in people without Parkinson's disease. So it's SSRIs, SNRIs, and any of these medications can also be effective. The only caveat would be that using adjunctive antidepressants, which are in the dopamine receptor blocking agent class, is contraindicated. So you know how we would treat people with the SSRI and add on olanzapine or uh, uh, risperidone if they're resistant to the antidepressant. So that would be contraindicated in Parkinson's disease. But any of the antidepressants can also be used for Parkinson's disease as well. The second part of the question was, what was the second part of the question?
How prevalent is depression among patients
Oh,
with PD?
yes, yes. So the range is up to 50% of people with Parkinson's disease can have comorbid depression. So it is very common. A misconception about depression is that people with Parkinson's disease are depressed in reaction to their Parkinson's disease diagnosis, and that is a misconception as well. The pathophysiology of depression and Parkinson's disease is related to the neurotransmitter imbalances that occur intrinsic to the disease itself. And there are many studies that document that people with terminal illnesses do not have as high an incidence of depression as people with Parkinson's disease. And yet, if we were thinking that it was a reactive kind of depression, then that should not be the case.
Um, there's another question here. What occupational therapy programs or implements can be used for patients with PD to avoid tremors and enable them to um, use their hands, like eat with their hands, write properly, and things like that.
Yeah. So occupational therapy, there are no specific programs that I am aware of that address tremors or micrographia in Parkinson's disease. There are many exercises that are being done to try to improve that, but I don't know that there is a specific protocol that has been developed, at least not in our programs, uh, that are specifically addressing the tremors and micrographia. The exercises, though, that are done by occupational therapists, they do the coordination exercises, uh, pegboard exercises, stretches of the hands, and the use of adaptive equipment for the tremors, but I don't know of specific protocols. The adaptive equipment, though, for the tremors, take note that in Parkinson's disease, tremors are resting tremors. So usually it actually does not impede people from eating or carrying a glass of water because it stops at when people are moving their hand, as opposed to people with essential tremors where they have more difficulties with ADLs, with activities of daily living, because their tremors are more postural and kinetic. So with Parkinson's disease, actually, it's more of the bradykinesia and incoordination that impedes them with their ADLs as regards upper extremities.
There is another question here. Are there any specific dietary recommendations for PD? Does intake of coffee worsen the tremors in PD?
Yes, caffeinated drinks certainly can worsen, and any stimulant can worsen tremors. Um, but the dietary recommendation right now, there's um, a lot of people are concerned about intake of protein with Parkinson's disease. And the reason for this is that protein can potentially interact with the absorption of levodopa. And therefore, there are some people who will find that if they take their levodopa with a high protein meal, that it doesn't work as well. My recommendation to patients is not to worry about that, because then the patients sort of get really vigilant about not eating or decreasing their protein intake. And not everybody will find that protein interferes or interacts with their levodopa. So I'd say eat the way that you would eat healthy, eat balanced. And if you find that when you take your levodopa with your meal, it does not work well, then and only then do you meal schedules to adjust to that, but not in the beginning. The other thing that we like to talk about is the Mediterranean diet. So there's a lot of research that shows that the Mediterranean diet is particularly healthy for the brain cells. So what that is seafood, shellfish, avoid red meats, fruits, vegetables, olive oil, the healthy fats, nuts. So think of the way that the Greeks and the Southern Italians eat, and that's how we must eat. We should avoid sugars, starchy foods, all of the junk food. There is no role for soda in our lives, and that really is not something that any of us should be consuming. The toxicity of these sugary foods is being shown more and more in research, and particularly for neurodegenerative disorders.
Another question we just got. Are there any herbal remedies or maybe complementary treatments for Parkinson's disease?
So there are a few naturopathic um, medications that have been looked into. The one that I am particularly interested in is mucuna pruriens, which is almost equivalent to levodopa in terms of its dopamine content. So mucuna is one, kava kava is another that's dopaminergic. So there's a few that contain dopamine. And the limitation of these naturopathic supplements are that research is limited. So there really is very or no scientific evidence of efficacy um, that for any of these substances. But certainly there are a few of these that have dopamine content and therefore potentially can be helpful for Parkinson's symptoms.
I think that's very helpful to know that because, as you know, in a country like ours in the Philippines, where resources are limited, we're always trying to find other alternative treatments. And maybe if there is some more scientific evidence, that maybe that could be explored. Another question: what are the sleep abnormalities associated with Parkinson's disease, and how do we address these?
Another talk again altogether. So the common ones are REM sleep behavior. So patients with Parkinson's disease, they talk about, well, their spouses or loved ones will say that they are very active at night, acting out their dreams. Insomnia and excessive daytime sleepiness can occur, and many reasons for that. Restless leg syndrome is also more common in Parkinson's disease. So yes, it's the whole gamut of sleep disorders. Excessive daytime sleepiness and sleep attacks can be a side effect of medication, as I mentioned earlier. So watch out for that if they are taking dopamine agonists in particular.
I guess we can take one last question. So, for the last question, is there any particular contraindication or a patient profile wherein you wouldn't start levodopa right away for PD?
Yes, so it used to be that the attitude towards levodopa was that we wanted to postpone the use of levodopa in our patients, and the levodopa sparing strategy was very common up until maybe 10 years ago. More recently, however, the studies have shown that there is no reason to delay the use of levodopa because the side effects and motor complications that we were concerned about, which was the reason we were delaying levodopa, actually was not because we started it early, but was more dose dependent. So long as you can maintain the dose of levodopa at 400 to 600 milligrams, then the likelihood of developing dyskinesias and motor fluctuations decreases. Um, Personally, in my practice, I usually still do not start levodopa as the first medication if the patient is relatively young. So younger patients with Parkinson's disease have a higher risk of developing these motor complications. Furthermore, with some of the milder medications like rasagiline or dopamine agonists, they can achieve good symptom control if they're still pretty early, and we can still save levodopa for later on because they have many more decades of living with their Parkinson's disease, and therefore we want to stretch out the armamentarium that we have over all those years.
Sorry, we have two more pressing questions. I think it would be important to address these two questions. So, first question: does the social and cultural milieu affect the progression of PD?
Um, I don't know in
Difficult.
what
Yeah.
context that question is being asked.
Yeah.
So if that is referring to a patient's social status,
Mm-hmm.
then I think that that would be related more to access of treatment. Um, that I don't know the context in which the person is asking that question. So if you're referring to social status, then certainly the limitation of that and the challenge is going to be access to treatment. But if you're talking about social um, opportunities, meaning a person is isolated, then yes, that can also affect Parkinson's disease in the same way that it can affect any chronic disorder, in that in the absence of socialization and activities that are more activating, then symptoms can get worse. But as regards affecting the progression of the disease itself, the pathology itself, then no. The effect on the disease is going to be more symptomatic and more in terms of the ability to treat it.
So for this last question, we wanted to ask this. We got a question because right now medical marijuana is a very, very hot topic. I guess in the Philippines, especially, they've been trying to pass legislation to legalize medical marijuana. And actually, as neurologists, we have been frequently involved even in Senate hearings to talk about where is the utility of medical marijuana for neurologic disorders. So, have you been using, or is it being used there for the treatment of Parkinson's disease?
So, Parkinson's disease is one of the indications that have been legalized in many states with medical marijuana. And I was again offering to give a talk, a whole talk on that topic as well. Medical marijuana or cannabinoids, in theory, have very, very interesting properties. And absolutely, the CBD component of marijuana can potentially have benefits. The limitation is, again, scientific evidence. So, all the years that marijuana has been legalized, but I mean illegal and criminalized, there has been no opportunity to do research. And even now that it's legal in the US, it's still very difficult to conduct clinical trials for marijuana because it's still illegal federally. So, in theory, there could potentially be benefits to cannabidiols, but in reality, we have no evidence for it. So there is a lot of interest in medical marijuana for many different, not just neurologic symptoms, diseases, but for many different medical illnesses. The neuroprotective property, the immunologic properties, so many potential benefits that we would love to be able to study further.
All right. Thank you very much, Dr. DeMarcaida. Thank you for all those questions to our viewers. And thank you again, Dr. DeMarcaida, for enlightening us with your answers. So
Thank you.
at this point, we would like to thank our sponsor for this webinar, Torrent Pharma Philippines. Thank you very much. So in summary, we learned from our webinar today that the efficacy of levodopa changes with the progression of PD. And it's very important in the management of PD, not just to improve the on state, but to also manage the motor fluctuations, because managing the off state and the toxicity such as the dyskinesias is also important. We also learned that there are various other medications available for the treatment of Parkinson's disease symptoms apart from your levodopa, and there are also surgical options that may be offered to our patients. So with that, we would like to thank Dr. Joy Antonello de Marcaida for taking time out of her busy schedule and for including us in her Thanksgiving dinner for tonight. Thank you for sharing your expertise with us today. So again, we would like to thank all those who joined us for this webinar, and we hope that you would join us again on December 13 for the Spirituality in Aging webinar. Again, thank you to our sponsor for this webinar, Torrent Pharma Philippines.
Thank you all.
Please also join the Advent webinar about faith and prayer in illness on December 6, Friday, 12 p.m. for the benefit of Pontificio Colegio Filipino and the upcoming UP Med webinar about dengue and polio by Dr. Anna Ong Lim on December 9, Monday, 12 p.m. So these are, watch out for the release of our Aging and Longevity webinars ebook this March 2020. It will contain 24 chapters on the topics discussed in our webinar. So please stay tuned for that. Again, these are Dr. Kimpo and Dr. DeMarcaida signing off. And please stay tuned for some reminders.
The Aging and Longevity Medical Webinars team of the Mu Sigma Phi sorority would like to thank our partners, the UP College of Medicine, UP Medical Foundation, and the Mu Sigma Phi Foundation. We are also grateful to support from the Postgraduate Institute of Medicine, UP Manila Information Management Service, and DOST-ASTI, and the PRC Board of Nursing. Most of all, we thank you, our participants, for spending your lunch hour with us. To receive your certificates of attendance, kindly answer the evaluation through the link that will be sent to your email addresses after you sign the attendance sheet for today's webinar. The certificates will then be emailed to your registered email addresses within 2 to 4 weeks. Here is a quick view of the schedule of our upcoming webinars. For more details and updates, please check our Facebook page at facebook.com/agingwebinars and our Twitter timeline at twitter.com/agingwebinars. Today's webinar recording and all webinar recordings may be viewed at YouTube at Aging Webinars channel. We are also announcing the launch of the OB Pearls book. Get your copies now. Thank you and have a great day.